Hi, welcome back. In this section, we're going to talk about identifying the symptoms that comprise a psychotic disorder. Now, it's important to understand that in psychiatry, all diagnosis is pattern recognition. If I were to show you this star isolated from the others around it, there's no way you could tell me what constellation it's a part of. But if I pull back and I allow you to see the whole pattern, you can easily see it's the Big Dipper. And this, what we call a pathognomonic sign, is a symptom that means if you have that symptom, you have that disease. And unfortunately, in psychiatry, there are no pathognomonic signs. All diagnoses are pattern recognition, and you'll see that's very clear in psychotic disorders. Now, psychosis sometimes is referred to incorrectly as a diagnosis, when in fact it is actually a symptom, and it can be a symptom of many different conditions. So how do you detect a psychotic disorder? Well, the main tool that we use to detect a psychotic disorder is the mental status exam, which is a baked-in part of any psychiatric interview. It's not a specific part of the exam, but rather it's the entire conversation we're having with the patient. We're paying attention to their level of consciousness, how aware and alert they are. Are they able to track what we're talking about in the conversation? We're paying attention to their speech. Are there any idiosyncrasies to their speech? Is it more slow than usual? Is it more fast than usual? Is there any disruptions in the musicality, or which is known as prosody, to the speech? What's their mood like? Mood is self-reported, but affect is what the mood looks like. We want to know, does the mood match their affect? And then, of course, very importantly, we're paying attention to their thought process. Is it linear? Is it circumstantial? Is it tangential? And the content. Are they talking about being followed by secret agents? Or are they talking about normal everyday things? The capacity for abstract thought is also impaired in psychosis, as can be memory, and certainly insight and judgment can also be impaired. So when we're looking at somebody with psychosis, if the person has had no history of psychosis and suddenly they're having an onset of psychotic symptoms, we need to ask ourselves some important questions. We need to ask ourselves, is this due to a substance use problem, either recent intoxication or even withdrawal? Could it be due to a medical condition, which is more likely to be a delirium presentation? And also we need to assure for safety. We need to know if the person is dangerous to themselves or to other people. And we need to consider any new onset psychotic presentation that has no clear reason for onset as a medical emergency until proven otherwise. It's a very important take-home point. And then we begin to treat the patient, or we begin to observe them, and we watch to see, does it clear or does it persist, the psychotic symptoms? So we obviously, if somebody's never had psychotic symptoms before, we need to do a medical workup to look for medical organic causes of their psychosis. And if we find those, if we find, say, lab abnormalities and we treat them, the question is, do those symptoms begin to clear up over time? And then we'll probably also use medications targeted to specific symptoms, such as anxiolytic medications for anxiety and antipsychotic medications for delusions and hallucinations. We want to make sure the patient is hydrated, well fed. We want to reassure them, because this can be very scary if somebody has never had psychotic symptoms before. And we want to make sure that the environment is free of any objects that could be used to harm the patient could use to harm themselves or the people around them. The vast majority of people with psychotic disorders are not violent, but you can imagine if somebody is very afraid and afraid that they're trapped, they might use an object to try and save themselves or to prevent themselves from being harmed. The medical workup for a psychotic symptoms, I'm going to list them here. The main things that you're looking for are things like a CBC, a renal panel, because somebody who's in acute uremia could certainly have some confusional psychotic-like symptoms, blood glucose, and drug screen, of course. If imaging is indicated, particularly if we think somebody has an organic lesion or they have a recent head injury, CT scan is usually a good place to start. And sometimes we do lumbar punctures to make sure that somebody doesn't have meningitis or some other form of infection that is affecting the brain. Now, what does psychosis look like on the mental status exam? Now, there's a whole cluster of symptoms, as I mentioned, a constellation, if you will. Now, on their appearance, it's not uncommon for people to be guarded, suspicious, or a little odd. They may make inappropriate eye contact. They may have no eye contact at all. They may have an idiosyncratic or unusual appearance, but that, of course, alone would not make for a psychotic presentation. Their mood and affect may be oddly intense, quick to anger, or it may be blunted. It may be very devoid of range, or the affect may be very inappropriate to the situation. The person may have come in from an accident scene and they're laughing intensely, something like that. Now, the language is very important. You want to pay attention to this when you're doing a mental status exam. So a common presentation is what we call a delay in response, or a increased latency of response, where you ask the person a question. Mr. Smith, do you know where you are? I don't know. Okay, see how there's a long space in between when I ask the question and when I got the answer. Sometimes this can indicate something called thought blocking. Thought blocking is also where a thought will just sort of stop in the midstream. So the person might be telling you about, well, I took the bus to get here, and then it just drops off. Sometimes there can be very little speech. We call this a paucity or a poverty of speech. And sometimes it's referred to as a poverty of thought, because it's thought that speech reflects our internal thought process. And so you may just get one word answers from the person when you're interviewing them. The thought process itself can sometimes be disorganized or nonlinear. So they're telling you sequence of events out of order, or bouncing around from topic to topic. It's not uncommon when you're interviewing somebody with psychotic symptoms to get a little confused yourself. In fact, if you notice that subtle confusion occurring, you may be dealing with somebody who has some subtle psychosis. And of course, the thought content is really important. Are they talking about people trying to harm them? Are they noticing, that would be paranoia? Are they noticing connections between things that other people are not picking up? Things that you might consider a coincidence if it was just one time, but if you start to think that there's a pattern to it, say all yellow cars with blue license plates are a part of a large conspiracy to track your movements. Those would be ideas of reference, because the yellow cars are a neutral object which is being imbued with specific meaning. Often this thought can be quite vague, or there can be a sort of obsessive quality of talking about one thing over and over again, or things are just don't make any sense, or there's this attempt to bring all sorts of things that really have no connection into one cohesive, over-inclusive loop. So as I was saying, sometimes that subtle confusion that you're getting when you're talking with somebody can indicate psychotic symptoms in a patient. But you want to listen to that story, because a lot of times if there are delusions present, they will emerge in the story. But high yield questions I will ask is, do you ever feel like people are watching you or following you, or maybe listening to your messages, or reading your emails? And then I'll ask, do you see connections between things that other people don't see? And sometimes people say, well, sometimes I'll get in the car and I'll put on the radio and the song will remind me of an old friend, and I wonder if they're thinking about me. I would file that under kind of just folk superstition, and probably not a psychotic symptom. But if it felt like every time the light turns red at the same time that it's a Monday, then that means that if there's a message for you coming from satellites. That's probably a psychotic symptom. And then if the person does describe paranoid symptoms, you want to ask them if they ever feel like they need to protect themselves or others. Because while I said most people with psychosis are not violent, if somebody has a sincere belief that somebody is trying to harm them, there's a good chance that they may try and protect themselves, and that can lead to harm to somebody else. You also want to make sure that you understand the beliefs in the cultural content or religious content of the patient. So beliefs that may be highly religious may not make a lot of sense to you if you don't share that religious belief, but it would be good to check in with a colleague who shares the religious beliefs of the patient to see if that's congruent with the group beliefs. You want to see if there's sort of a systematic pattern, or are they disorganized? And you also want to see how intensely those thoughts are held. Is a person open to shifting their thinking, or are they really fixed on it? And then you want to think about, well, what are the actions that might result of this delusion? If the person feels like they have a tracking device inside their belly and they need to cut it out with a knife, you can imagine that would be a really terrible outcome. And it's generally not a good idea to directly confront delusions, because they often with these delusions will kind of double down if you confront them, but rather to ask for more details, or say, do you really think that's happening? And if they say, oh yeah, of course, probably don't push harder on that. But if the person says, well, I don't know, maybe, maybe not, then maybe there's some loosening to that delusion. Some common kinds of delusions, the most common one is probably paranoid and persecutory delusions. These are ideas that people are following you or trying to harm you. And then ideas of reference, as I mentioned. Grandiose, I am going to be the next Mark Zuckerberg. I am creating a computer system with my mind that will track every human being on Earth, and Mark Zuckerberg only managed to get 2 billion people to sign up. I'm going to have all 7 billion people in my computer system. That would be a grandiose delusion. Somatic delusions are fixated on the body. So I had a patient once who every morning when I saw her, I'd say, how are you doing? And she said, I was filled with wax last night. The nuns came down and filled my body with wax. So she had this somatic delusion that she was being harassed in this way. And then guilty delusions, like the person believes that their thought process is influencing some larger global phenomenon. So those are common too. Not terribly common, I should say. Delusions of jealousy. So this would be, for example, Gavin Newsom stole my wife when I was in elementary school. So a little bizarre, but definitely with a flavor of jealousy. Religious delusions, such as my mind is being controlled by God. Erotomanic delusions. These are rather unusual, but kind of fascinating when you encounter them. I treated a patient once who was convinced that everyone at his office was having a secret sex club and they wanted him to join. And he had all these ideas of reference that anytime somebody said, hey, do you need a pencil? They said, well, I know what that means, of course. Right. So that would be an example of an erotomanic delusion. Delusions can sometimes be very bizarre. I knew a man once who would who would put bananas in his ears and put tape over it because he was convinced that there were earwigs eating through his brain, but they liked fruit more than brain. So he could get them to back out that way. A very uncommon type of delusion is called a folie à deux, a wonderful French phrase for a shared delusion, where two people, usually often in a couple, believe that in the same delusion. So in this case, well, of course, the CIA is following my husband. He was the leader of SEAL Team 6. And of course, the husband was not the leader of SEAL Team 6, but he has a delusion that he was. And then finally, nihilistic delusions you can see in severe depression. So for example, thinking that you're actually really dead and maybe everyone else is still alive. So this paranoia, very common, very, very common. And this, it's clear that you need to understand this exists on a continuum. Some people have a slightly paranoid personality. They're not fully psychotic. And other people can have florid paranoia and psychosis. And remember, something may sound kind of odd, but it may turn out actually to be true. I had a patient once years ago when the therapist called me to refer this patient. She said, she's going to tell you she's a CIA agent. And she actually is. So this quote from Kurt Cobain of just because you're paranoid don't mean they're not after you. So when we're evaluating for hallucinations, so hallucinations are different than delusions. Hallucinations are things that sensory experiences that other people are not having. So the best high yield question of this is usually around auditory hallucinations. I'll ask, do you ever hear voices that other people can't hear? And if they say yes, I ask them, when did it start? Is it happening all the time? Are there certain situations that bring it on? And what do they say? And which is really important. Very often these are really kind of cruel, taunting voices. And then I'll ask, do they ever tell you to do anything? Because that's really important. And then I also want to know if they get in the way of the person's life, because it may turn out that they're not really that bothered by them. Now, disorganization in psychosis is an important thing to understand, particularly with schizophrenia. Now, in the disorganized symptoms, these are characterized by sort of inappropriate affects. So the person may get angry and start yelling when there's nobody around. They may behave or appear in a very bizarre way. I'm sure you've probably seen people that are homeless in San Francisco who might might be described by this. And then when you talk to them, their thoughts are often very disorganized. Things don't make sense, or everything is kind of piled in at once. And they often have difficulty with abstract thinking. This picture here is a gentleman by the name of Grimes Posnikoff, and he was a street musician in San Francisco in the 1970s. He had this contraption here where he would set this up near Fisherman's Wharf. If you put a coin in, he would pop up and he could play just about any song he wanted on the trumpet. Sadly, this was Mr. Posnikoff just before he died in 2005. He had paranoid schizophrenia and was living under a bridge, and as you can see, is quite disorganized and living in squalor. So this part of the illness can have a progressive course. So in our last few minutes here, I just want to give you a flavor of what it might feel like to have a psychotic disorder. And to do this, I've borrowed a snippet of a song by a band called The National. And this song is called Afraid of Everyone. And I've kind of highlighted in the lyrics where these symptoms start to kind of track onto our what we've been talking about here today. So if I can get this to work.
Venom radio, venom television. I'm afraid of everyone. I'm afraid of everyone. They're the young blue body with the old red body. I'm afraid of everyone. I'm afraid of everyone. With my kid on my shoulders, I try not to hurt anybody I like, but I don't have the drugs to sort. I don't have the drugs to sort it out. Sort it out. I defend my family with my own umbrella. I'm afraid of everyone. I'm afraid of everyone. With my shiny new stuff, spangled tennis shoes on. I'm afraid of everyone. I'm afraid of everyone.
So I hope that gives you sort of a flavor of what it might feel like to live inside the mind of somebody who's developing psychosis and how frightening it might be. Oftentimes, we as providers and sometimes we as the public are very afraid of people with psychosis, when often it's the people with psychosis who are actually quite terrified. So in our next section, we'll talk about some of the specific diagnoses that we think about with psychotic symptoms.